In the same theme about whether I would have done anything differently. This is a case I remember happened in 2015, I believe. Yeah, so he was a young man. I mean, he was 55. He's now 62. He was an electronic engineer. Came to see me after being referred to the ophthalmology service with a large pituitary tumor. He had a visual deficit, quadratic defects, superior quadratic defect from this large pituitary tumor. So you can see the giant tumor has got lobules around the ACOM complex. All this knobbing you see are where the tumor is trying to grow between the ACOM complex. And this is what happens when you have tumors which trying to push. You can see that even it is pushing the genu of the corpus callosum upwards, and so it is exerting a lot of pressure. But interestingly, the vessels tend to hold more strongly than some of the other neural structures, and the way it extends through this areas behind the ACOM or in front of the ACOM, and also to the sides of the antecephalous arteries. So this is why it gets that shape. So that's the axial view showing the incorporation of the antecephalous arteries. All this grooves within the tumor are where the vessels, and this bright spots are the vessels inside the tumor. So it was not a straightforward pituitary tumor, even though it's not unusual to see pituitary tumors of this size in our practice. In fact, if you look at all the pituitary tumors, around 15 to 20% of them could be large, giant tumors. Some of them could be functioning, such as prolactinomas, but there are many of them. In fact, half of them could be non-functioning. You can see the way the tumor was growing and partly going into the frontal lobe here. All these vessels are inside it. They're not strictly inside it. There is a pseudocapsule separating it, but it is encased around it. And this will come to our, if we can look at the classification of the grading of the supracell extension, just to remind the trainees in the group, there are classification based on the extension of the tumor into supracellular space, depending on how far it's extending, whether it's extending up to the third ventricle or whether it's going on to one side, to the frontal lobe or temporal lobe. You can grade them. And also the sideways extension, we often use the NOSP classification. So angiographic image would tell you how much the vessels are displaced. Here you could see that the antecephalous arteries were sort of displaced up, elongated, and they are much lifted up. In fact, I remember for tuberculum cellular meningioma, we used to call this as a guard of honor sign. When the heads of state visit other places, they get a guard of honor. Just like that, in meningioma, especially supracellular tumors, they tend to lift the A1s up, so you get this guard of honor sign. So this is fairly similar sort of appearance on the angiographic image. The sagittal CT, you can see the sinus was pneumatized, and the cella was expanded. Tumor was going into the cellular floor. He had all the workup, endocrinological, ophthalmologic workup, and the planning with the reconstructed image of the carotid arteries and the circular villus and the large tumor. And this being a large tumor, I planned an extended endonasal approach rather than a standard transcellular approach. Because if you go back, you can see that the tuberculum here, ideally, if you take it off, you could get all this out. So this is the standard exposure for such a case. The cella is here. You can see the cella is filled with the tumor. The exposure is from the paraclinoid carotid to the paraclinoid carotid, and the planum, and the planum cella, the dura is being opened up. This is where the anterior intercalamus sinus, the limbus is here. So the dura is being reflected. It's not the usual opening for a pituitary tumor. Normally I open it like a cruciate incision. So the tumor is now being exposed. It's soft tumor, and you can also see in the planum the tumor was coming down into the exposure. So the dura is being dissected off, and soft tumor but vascular. So the initial exposure of the tumor is fairly soft, as long most of the pituitary tumors are, and as you can expect, they are vascular as well. And part of the debulking, you can see the anterior vessels are appearing on the upper surface. This is the A2s bilaterally, and can you imagine there will be a pseudocapsule which is also attached to the arachnoid here. So there is no arachnoid attached to it. So it's important to make sure that these perforators are preserved and they're not damaged by trying to peel off the arachnoid off these vessels. And most of the operation was intratumoral, intracapsular, but there are tumors around the side base as well. So we'll go on. So this is the side of the tumor is getting exposed and removed. That's the supraclinoid carotid going up. So this is the just to confirm the position of the supraclinoid carotid with the Doppler. Okay, so the navigation is useful to locate the extent of your operation, and all this reconstructed image will tell you where are the vessels A1s and A2s are displaced by the tumor and how the tumor is growing between those sort of corridors. Here, this is the ACOM complex here. The chiasm is here. The pituitary stalk and the pituitary is at the back. So everything is in front of the sella. And this is the A1 on the left side. This is hidden behind the capsule, but you could still see it. So just to correlate the anatomy, so this is a cadaveric picture showing the A2s on here. The ACOM is here. A1 on the left side, A1 on the right side. On the left side and on the right side. So the tumor was going all around these corridors, and part of the tumor was going into the frontal lobe. So which is what you see here. So this is the part of the tumors being removed from the front of the ACOM. The tumor around this corner and also towards this corner. So it's important not to disrupt these perforators which are coming back from the A2s, and be careful with it. So these tumors are this is the tumor being removed here, and you can see there was no plane which is emanating to the brain on that side. So it's fairly large exposure. It's about 2.5 to 3 centimeter long incision, final flap. So he did well after the operation. I was oriented and talking, and I was pleased that he did recover his vision as well. And he did an MR scan the next day. The tumor mostly was removed, and could still see whether the fluid was within the cavity. And there was a little bit of tiny left behind here, but he remained well. So I was not concerned from a neurosurgical perspective. Unfortunately, on the 4th day, he started having intestinal bleed, subsequently also developed respiratory distress, and had to be shifted to ITU. His respiratory distress worsened so that he had to be intubated and ventilated. And also his X-ray chest and subsequent scans have shown a lobar consolidation, and his intestinal bleed became a real problem. He started having significant loss, and hemodynamically he became unstable, had to have several units of blood transfusion. And the intestinal specialists have done the endoscopic investigation, which revealed some mucosal erosion. There's nothing more major ulcer or duodenal ulcer or anything that require any surgery, but he was losing blood. And the scan we did while he was in the ITU with ventilated showed this hematoma. It was, I suspect this was a fluid. It's not a very a significant clot. It's just a fluid blood, but that time he didn't have any other concern. But after a scan subsequently revealed that he had significant pneumocephalus, and also in the ITU he started leaking CSF. So we were concerned, so we had to take him back to theatre to repair it. So this is when he was very sick with all this bleed going on, when hemodynamically unstable with a low hemoglobin, and so things were getting more and more complicated. And also had developed collapsed lung, subsequent CT pulmonary angiogram revealed pulmonary embolism. So he had to have an IVC filter put in. So we are in a situation where he has got pulmonary embolism, and we cannot really heparinize him or treat him with anticoagulation because he's having ongoing issues with his intestinal bleed, and also had recent endoscopic surgical repair of his leak. And from a neurosurgical perspective, the leak stopped, and the wear in the ventricles got better. And these are he had multiple stages of intervention procedures for his intestinal bleed. In fact, they found that his celiac artery was quite stenosed at the base, so he was getting collateral circulation in that territory by other mesenteric branches. Possibly it all contributed to his intestinal bleed, and you can see the coils in the mesenteric artery, and at the background you can see the inferior vena cava filter. So he spent some time in the intensive care unit, and had to have a tracheostomy and subsequent CTs, and also later on found that he's got femoral and iliac vein thrombosis, and he did have an IVC filter put in, so we didn't have to do anything about it. And subsequently we removed the external ventricular drain, and he can see some low signal sort of low density areas in the anticephalotic territory, but there was no extensive anticephalotic infarction. After he came back to the ward, he recovered to some extent. He was still quite disabled by all these procedures and the bleed and the ischemic changes, and he was sent to a rehab unit to a local center. And this is a scan they did a month or two later, where they did this MR scan. You don't see any tumor. You can see the fat graft after the repair, but you can also see this anticephalotic infarction, mostly on the right side, a little bit on the left side. So it was not there when he was with us. So it sort of developed a delayed ischemic response to all these procedures. When the family came to see us after he was in the rehab unit, and they said he was making slow recovery. He was able to speak. He did have some weakness on the left side. I was actually astonished to hear that they were not discussed in terms of the risk involved, because when I met him, he was alone, and that was a bit of a surprising thing for me. In many countries, when you see patients, they come with their whole family, and the whole family will be there to support this patient. But in many countries, especially in Western world, they come alone because they are very individualistic and they don't really want to bother their family. But such a big operation, the family didn't know about it. So this is something which I was surprised about. So what is there anything I would do differently? I often used to wonder whether draining that liquid hematoma, whether it would have made any difference to his eventual outcome. Probably not, because he remained clinically well in spite of having that hemorrhagic cavity inside there. I think overall the multiple episodes of his hemodynamic instability may have contributed to his anticephalotic infarcts, because there was manipulation of the anticephal arteries. There was blood around it, and added to this with the bleeding episodes that may have prompted the ongoing delayed ischemic changes. And on top of that, we had another complication issue of pulmonary embolism, and which we could not really treat with anticoagulants. And also, we also had to deal with the leak and pneumocephalus, etc. But one thing I would have definitely since then, I think even if they don't want their family to be involved, I think we have to make every effort to get the family, because once something happens like this, it will be the family who will be looking out for these patients, and especially if there is a cognition impairment, there is no excuse. So my take-home message from this case would be, even if it is not so major case, I make every effort to get the family in the clinic or even beforehand to have that discussion. I think that is it. This is my team here. Also, you can see my hospital and the sculpture, which is the shape of a spine, and these small individual things are made in the form of a female torso stacked up like a vertebra. It's a famous culture called Com Femi. Thank you very much. I'm going to stop sharing. I would like to hear the comments.
Thank you very much, Ramesh. Imad has a question, but before he goes, just say that we all very much recognize the difficulties associated with the giant pituitary adenomas. They come in all sorts of shapes, sizes, consistencies, etc. Imad.
Yeah, actually, the situation is an unlucky situation. It's a multifactorial problem, as you said, whether it's the intestinal problem and the lung embolism. I have confronted with a similar case on a craniopharyngioma that I attempted to, by default, to take it from below with some calcification. And I have the same situation. Everything was clear, subarachnoid dissection. And I saw these perforators you pointed out. This, I think, sometimes is a source of problem, like in vasospasm. That's what you have it, even if you go from above, sometimes you have vasospasm. And I think stroke or infarct related to these vessels, that's why the delayed effect of it rather than earlier effect. It's not a bleed per se immediately by the procedure or by the technique, but it's a delayed, perhaps sometimes unnoticed, some traction injuries on this perforated that can lead to these vascular. I just want to mention vasospasm can occur by this procedure.
Thanks. Thank you.
Yeah, that has.
Yeah. Andre?
Yeah, indeed, that has been described. And actually, I'm right now, this week, I'm writing on a report as expert witness on a similar case. And that was vasospasm, because for nearly 48 hours, that patient was well. And then at the end, he developed bilateral thalamic infarctions. And there was some, the diaphragm was open, so there was some blood in the suprasellar cistern on the post-op CT scan. But what adds to the problem, and I think that Ramesh pointed it out also about the family, if so many other issues evolve later on, and that was also in this case with a lot of tracheostoma, long-term in the ICU, multiple other specialisms are involved, the family hears, what they hear are 20 different stories from doctors. We tell them our neurosurgical view, and we see some liquid blood in a field. The ICU doctor tells the people he has a bleeding in the brain. And so they all give different opinions on the situation. And that adds to the confusion. And at the end, loss of confidence in the doctors, in the medical team. So therefore, it is so important, even if there are multiple other complications, that the neurosurgeon who treated it first remains the captain on the ship and is in a daily, preferably daily basis, the person contacting the family. That was so obvious in this case. I'm just busy writing it all down now. And that's because this typically happened afterwards. There was at the end, the feeling of somebody for 1 year in a rehab center, and the family say, how is this possible? We heard a lot of different stories, and it comes from this and it comes from that. Early involvement, and at the end, always be available as neurosurgeons. And I tell that to the young people. Don't leave it to others. That's so essential, because it's all pointed to your surgery.
Yeah, totally.
Lots of very important points there.